All right, today on Your Health, we are talking about health law and focusing a little bit on medical tourism. And my next guest is a certified specialist in health law. Tracey Tremayne-Lloyd she's been practicing health law for more than 2 decades and a specialist by the Law Society of Upper Canada. And she joins us on the line. Tracey, thank you so much for being here.
Thank you for having me, Jill.
It sounds like it's changed a lot since you first got involved in health law, in that there wasn't a lot of attention being paid to that particular area.
That's right. There was virtually none. Health law was not even a legal discipline at that time. Health law was always thought to be, oh, you mean malpractice lawsuits, which is not health law at all. Health law is an administrative discipline. It's all regulatory, government-made law, and it's one of the most highly regulated disciplines now that we can get involved in.
And would you focus then on the Canada Health Act and how that's upheld, or are there certain areas of health law that you look at?
That's one of my main focuses, is the Canada Health Act, how it is implemented in each of the provinces, what is legal and what is illegal in terms of delivering health care, payments for health care, whether patients have options with respect to opting in or opting out of the system. That's a major focus of a health law practice.
Let's talk a little bit about some of the cases in Ontario, and some of the news stories recently in Ontario have to do with medical tourism. I would imagine this isn't just happening in that province, but explain a little bit the concerns with hospitals advertising or hospitals drawing in people from other countries for medical treatments.
Okay. Well, I agree with you that it can't only be an Ontario issue. I would imagine that for sure major cities like Vancouver, major hubs like Vancouver must be experiencing some of it as well. But what we call international patient programs have been happening in Toronto since about 2010, 2011, but they were never openly marketed. So what happened was the University Health Network was probably the first to make serious money in treating people who were coming into Ontario for medically necessary care and procedures. So just to give you an idea, it was a slow and steady increase from the time that UHN started to reach out and essentially market, but not openly in Canada, but elsewhere, about the high quality of care that could be provided in the University Health Network in Toronto. So, for example, there was an influx of patients when that started to happen, and in the first year they made something in the range of $2 million net after they started. But then when we got to 2011, 2012, they made $11 million net from this tourism. So, and then in 13, 14, they expected it to be around 7 to 10 million. So what happened was Sunnybrook, our other large universal academic center, thought, well, this is great. We can find some money to put into the system by doing the same thing. But they openly marketed it, and they made a website and all of that. But what the catalyst was to bring it out in the open was that I think it was 2014, 81 Libyan victims of the civil war were brought to Toronto en masse, paid for by the Libyan government, to receive medical care in the University Health Network hospitals. And a male nurse who saw these patients en masse said, what's this? Why have we got all these foreign patients? What's that going to do to the wait lists for our patients? Wait lists are already terrible. So that's brought it to the fore. So now there's a whole issue about, is this good or is this bad for Ontarians? And that's true all over the country. So if this is going on, these international patient programs are going on everywhere. The crux of the question is it better or worse for Canadians? Are Canadians being displaced, or are they not being displaced? And is the revenue that's being generated actually going back to improve our system and to improve the delivery of care to Canadians? Will it reduce our wait lists? Will it help our system? Because whether we like it or not, there's just not enough money in the system. The system is broken. It's only going to get worse unless we find money elsewhere to pour into the system so we can preserve it for Canadians. So that's the crux of the question. Is it really helping, or is the money disappearing into some big abyss? And are we actually not doing this work after hours in operating rooms that would otherwise be closed? Are we actually displacing people off the wait list to find this money?
And do we have answers to any of those questions?
We don't yet. I think it's an interesting situation that's now starting to be investigated and reported by the people like yourself in our news programs, in our health programs, and the medical press. And what they want, and I think this is right, what we need now is transparency. I don't think Canadians are adverse in any way to these types of programs, as long as they are assured that it is assisting our universal health program, that is going to reduce our wait lists and be better for us and not worse. But we don't get any transparency. They don't file financial statements. They don't say how much came in and how much went out, and what timing was this work done by, and how did they use that money? Where did it go back into the system? Which areas of wait list did it reduce? Which operating rooms did it reopen? And I think that's the key, is that, and it's there's no transparency on what's happening with the money.
Well, how is that even able to be happening in that, I mean, it sounds like they're operating as private companies, as private clinics.
Yeah, that's very interesting. In a way, that's right. It has all the hallmarks of people running, the management of the hospitals, running the hospitals as if they're private businesses and that they're not accountable. But they're not private businesses. It is taxpayers' money, and they are accountable. So I think that's where the ministers of health in every province have to begin. They don't have to say, you can't do this. I think that's precipitous, and it might be detrimental to our economy and to our healthcare economy. What they should be doing is say, show me. Show me so I can show the public. So in Ontario, for example, when this blew up, just in the last couple of months, the Minister of Health in Ontario wrote a letter to both of our academic centres and told them to just close the program down, to stop it. UHN didn't do it. They ignored the letter, but Sunnybrook, they did do it. They did not ignore the letter. But you can't govern by knee-jerk reactions. It seems to me you've got to look at the issue. We don't have enough money in the system. If we can bring in millions of dollars of extra cash that's going to benefit the system and help Canadians to get better care, to get more timely access to care, then that's not a bad thing. That's a good thing, including the fact that all these people spend other money in the economy. They're in hotels. They have entertainment. They bring families here. So first let's examine it. Let's know the answers. And if it is affecting us adversely, then by all means we have to stop it. But if it is not, then what we need is total transparency, it seems to me, so that Canadians know the answers.
Well, and I think you're absolutely right when you say if we were assured that, yes, the operations were taking place in rooms outside of the normal schedule, if the money was going back into the system, people would probably be okay with it. But if we don't know that, then there are all of those questions. Is this why the wait list for people is so long? Is this why we can't get an operating room? And is this being a negative thing?
Exactly right. That's the crux of the question. Like, are you actually, where are you, what are you doing with this money, and when are you treating these people? And how are they inpatients or are they outpatients? So, for example, if they're inpatients, it's all well and good to say, well, we operated on them outside of normal hours in an operating room that we had closed because we can't afford to run it. But then what if they're inpatients? You can't say, well, sorry, you got to go now because it's morning. They're going to have to be looked after in beds, right? In beds that maybe Canadians should be in, and they're going to need care through the day. So I think there's a lot of questions, and if it's a program that's going to be embraced, I think it has to be an open discussion with Canadians, and Canadians have to know and see how it's benefiting our universal system.
Well, is there also the question, too, or the concern from people as to why is it that somebody from Libya, and I'll use that example because you used that example of people from Libya. So why is it somebody from Libya would be allowed to come here and pay for, let's say, a knee surgery when I, a Canadian, technically can't pay for a knee surgery?
Oh, that to me is one of the most pressing questions in our system at the moment. The fact that the government prohibits Canadians from getting out of a queue. It's, to me, that's the most absurd part of this question. And I think that is something that has to be addressed. I mean, why should you, as an individual, if you want to spend your after-tax dollars and stay in your own country and have it done? And the question there for me would be you can't double dip. So if you want your knee surgery done, you've got to get back to work right away, and you're going to spend the money you were going to spend on a vacation to get that surgery done in a private outpatient clinic. I don't think you should be using our hospitals, and I don't think you should be able to get any part of that feedback from our system. In other words, you're either in or you're not in. As a patient, I'm talking about now. But you're not allowed to do that. They'll say, oh, yes, you are. The patient can do that. But they prohibit our physicians from doing it. So, in essence, you can't do it, which is why you're going to Seattle and why Ontarians are going to Buffalo. And they're taking our dollars that could be going back in our economy out of the country. It's completely nonsensical. It doesn't make any sense. And if those people are out of the queue, it seems to me the people who really need to be done in the hospital, who don't have the ability to pay out of their after-tax dollars, would be, if they're behind you in the queue, they're going to move up a space. Do you understand what I mean?
Yeah, exactly.
And that has got to be addressed because Canadians are going in droves with their recreational dollars elsewhere. And that, to me, I think it's wrong also. Why do we have to go out of our own country, away from family, away from friends? Why can't we be seen in a private, freestanding facility that is run on non-taxpayers' dollars, but still keep a universally accessible system? There is a balance. Other countries do it. There is a balance.
Well, and in many cases, too, whether people want to admit this or not, it is being done. I mean, recently I had a loved one who had to get a test done. And in the public system, we got a letter from the doctor. It said the wait for this test is 3 years. But if you want, you can pay $1,000 and I'll do it at this private clinic next week. Well, which one do you think we chose?
Of course. Now, I have to tell you, don't tell who that doctor is on air. Because you're going to get somebody in terrible trouble because technically, if it's a medically necessary service, it's covered by your plan, and the patient doesn't get into trouble for it. The physician will get into trouble for it, or whoever offered the service, unless there's some very good explanation of why they could do that. So that is a problem, and the governments don't want to address it because it doesn't get votes. They worry that people think, oh, we're going to have a two-tier system. That is not a two-tier system. We must preserve our universal system. But it's not timely and accessible right now. It's just, look, that's a good example, the 3 years. The cataract surgery in Ontario for a while was over 3 years, and if you get to 3 years, you lose your sight in many cases. So this is not timely or accessible, nor, in my humble opinion, is it acceptable for the kind of health care that Canadians deserve. So I think that this debate simply has to be had, and we have to be able to balance the preservation of our universal system with a way to generate funds that will reduce our burden on the budget for health care.
It is certainly an interesting topic. Tracey Tremayne-Lloyd, I appreciate your time so much this morning. Thank you so much for being on the show.
It's my pleasure. Thanks, Jill.
All right. Tracey Tremayne-Lloyd is a certified health specialist. She has been practicing health law for more than a couple of decades. If you want to join the conversation, maybe you have a similar health story, by all means, send me an email, weekendnews@cknw.com or jbennett at cknw.com, and I'll share some of those a bit later on in the program. Much more coming up here on The Jill Bennett Show.